which means they're gonna numb your extremity for your procedure, helps with pain control. After the procedure, as well as it helps the anesthesiologist use less medicine during the procedure to keep you asleep.
Okay.
I'll do it. I'll do it.
Picture of her then, since you just did.
We are doing this, we're going full out, right?
Huh?
Yeah,
And just for convenience, I'm gonna just put it here, here, and here, so that.
It's not working. Oh my gosh, you're dead already.
Yes.
Give us something.
All right. There's Denise.
Dr. Stanley. Patient Stanley. Patient Dr. Stanley. Would you like to cover up? Are you cold, sir?
No, I'm fine.
No, okay, so we're gonna put a little bit of oxygen on you. We do that with everybody that gets a block, you know, a little extra oxygen for good measure. Okay?
A little annoying at first, much like myself. Okay.
Looking good, looking good.
So here's our first patient. Now, of course, you're gonna have to use your imagination a little bit. First case study. We have a 42-year-old female.
Figures. Really good.
Yes, we do. Yes, we do.
For rotator cuff repair under general anesthetic with an interscalene nerve block for postoperative pain. She is the first patient of the day to start at 7:45. She is morbidly obese. Her BMI is about 50. She's very anxious and has a mild developmental delay.
Yeah, this just gets better and better. Thank you so much.
I like that he didn't have to do as much acting as one might think. Okay, so here's what happens. Patient arrives late, of course. Difficult IV stick. Doesn't have anything to do with the quality and the skill in the facility. It is now 7:38. Due to anatomy, locating adequate sonoanatomy is difficult. Patient is squirming a lot because of pain and multiple needle passes. Procedure is prolonged.
Can we give more medicine and IV?
I think we should. Ultimately, this patient requires 5 milligrams of Versed.
All right.
This is not where it normally is.
5 milligrams.
Yeah, we do happen to have 5 milligrams right here.
And I would love to give 5 milligrams of Versed.
And notice that it's labeled appropriately. Okay.
It is. Of course, I would make sure it was.
Patient requires 5 milligrams of Versed due to the severe anxiety, making communication even more difficult.
The vital signs are stable still, right? When I'm pushing my Versed.
Yes.
Under the
Of course,
great
you check
supervision of the
everything has been fine. SAT's fine. So, when we give the injection of local anesthetic, we don't just take the whole bolus and just shoot it all in. We give 5 cc's, aspirate, we aspirate, give a little bit of time. So when we're giving that last little bit, let's say that we gave a total of 30. As the final portion of the bolus is injected, the anesthesiologist is called urgently to the OR for a difficult intubation. So if there was an anesthesiologist here, you're on your own. The CRNA and OR nurse arrive to take the patient to the OR and greet the patient. We'll just pretend like all of you were playing those roles in. All right? While the block nurse...
I have one more question.
Oh,
Did
yes.
we get all of the medicine in before he left the room? All the medicine got in? Or we were...
Because he's got the needle...
So the needle's still in when he left the room, or the needle is
No,
out?
he would pull out and,
Okay.
and run off.
Just checking. I just
question,
needed to know
good
this.
question.
This is
Using
serious.
our imagination here. Okay. While the block nurse is recording vital signs and has her back to the patient, the CRNA, whoever that might be, we'll just pretend that you're all here as a CRNA, asks the patient if she feels any tingling or numbness as she removes, I guess I'll be the CRNA, as she begins to remove the EKG leads and nasal cannula. And sorry about that, miss. The patient responds, there's your lines.
Yes, my lips.
They must be.
My lips are tingling. What is that loud noise?
Oh no.
Patient spasms twice, closes her eyes, and begins seizure activity.
All right, I'm gonna get him. Am I allowed to go ahead and go? Or?
Yes, what should we do?
We're gonna get her on her left side if she's having seizure activity. We're gonna hook her back up to the monitor. We're gonna put the oxygen back on her. We're gonna get the doctor back in. We're gonna get the lipids going. But I am only one person, so I'm gonna start with the left side.
So are you going to do it all yourself? Or
No,
you're going
because I
to?
have
You said I'm
helpers.
gonna
You
start
have-
with the left
I'm
side.
gonna start with
Yes.
the
She
left
hit the
side.
code light.
And she hit the code light.
Boom.
Okay?
But I thought I had helpers already in here.
Yes, everyone's standing. You have an OR nurse.
Somebody help me.
Someone pretend to be an OR nurse and a CRNA.
What do you mean?
You're awesome. Okay, so you're here. You're also.
Where's that? We need a CRNA.
Okay, so you said you called for help,
Yes.
and you said you're going to get the.
Oxygen, I'm putting back on there.
Oxygen,
We gotta
very
get
good.
lipids started because he just had a block.
You
so
were
we're gonna go with
requested.
inner.
Yep, and here's our CRNA. There we are.
Our
Good.
CRNA, will you get the lipids out of the bag so we can start
Yes.
this
So you
process?
make sure the box is immediately available. This is awesome.
And then we'll make sure our suction's set up because if he is really seizing this,
I
we
will
need a
save
suction.
you, Dr. Stanley.
I will save thee.
I already see.
All right. So here's okay. So as you're doing that, absolutely, and that was one of the tricks. Notice the CRNA came in. Of course, everything's cool. I'm getting ready to take these things off, and here we go. We want to know. We obviously have neurologic symptoms. We know very shortly because this has happened. So fine acting. I think you have another career. But it's occurring so dramatically and escalating so quickly. We know cardiovascular symptoms are probably right behind, right? So we got those back in, and we didn't miss that. Okay, so you got them out, and you hung it. Now, when we give it intralipids, how do we give it?
I would hook it up to the IV because once you use that IV line, you can't use it for anything else other than lipids.
Okay.
And
So you start an infusion.
Isn't there a filter?
Is there any other questions or thoughts or?
there usually because lipids in the hospital come in like a bottle, don't they? Usually, like in the hospital, I thought it was a bottle.
Oh.
So you had to have you have to
Okay, so-
pump the.
I'll cut to the chase.
Yeah, do that.
We're gonna start it as a bolus. So when you look in your pharmacy box, it's got everything you need, right?
It should.
Including a 50 cc syringe, or it's a 60,
Okay.
and not that, that's for another drill. 2 of those. So you're gonna have a bolus. How much do you bolus right off the bat? And you've also
50
got 50 at a time. Okay,
times 2.
times 2. Here's the textbook answer.
Very good.
1.5 mLs per kilogram.
And she said
She weighs 355 pounds. How much do you give? The answer is, who cares? The answer is, literally, because they're not going to do math while she's seizing and starting to have cardiac. The answer is just give 100. Okay, the answer is give 1.5 per kilo. Most people are like 70, so that's kind of 100. In this kind of emergency situation, the circumstance is this. Give 100, we'll do the math in a minute. Because if that is not enough as we're starting the infusion, you know what we're going to do? We're going to bolus again. We're going to bolus again. So the answer is, I don't really care what the exact number is. It's about 100. We're going to start with 100. And the fact is you have 2 syringes that you can put 50 to 50 in.
Oh, you really want me to do this?
Mhm.
Okay.
And here's how I want to look at doing this. Here we are, like I said, the clock is ticking, right? So you're putting that on, you're popping it out of here.
Really popping. You
Mhm.
really want me to do
Yeah,
this?
that's milk. It's not really lipids.
Oh.
Oh, I gave away one of the clues. And you're helping because you're like, oh, that looks like a lot of trouble. And I'm managing the airway. I'm watching the
He's
rest of
moving.
it. Look, it
Ripping.
seems to be doing just fine. I don't know why. Yeah, it's because
You punctured.
and you notice
I did.
we have blunt needles in
And
here.
this is exactly what would happen in emergency.
That's
Just
exactly-
letting you guys know.
You know what really would happen is you would do it really fast and you'd stick it in your thumb.
No, don't say that.
So see,
I
we got
did
that
once to my
so
finger.
far so
It was
good.
like a stun gun.
All right. So let's just say, obviously, you see this takes just a minute, but let's just say you've got 50 now.
Say, I really wish I did. Wow, that's harder than it looks, everybody. Just like, you know.
Right. That sounds like a good drill to have done. Right. So you notice these 60 cc syringes are possible. You're just pulling it out, pulling it out.
This is a filter needle. Are you supposed to use a filter needle? That might be why it's not really working. Yeah,
Okay.
this is a filter needle that we have.
So let's fast forward. Awesome. So now we know that. We'll change from those. Okay. So
I
fast
thought you
forward.
wanted me to
Let's-
have a
yeah,
filter needle.
Let's pretend like that's 50, whether it is
Okay.
or not.
Right.
Now, you see how much trouble that took? That took 10 seconds, 20 seconds, 30 seconds, 40 seconds.
And that's all time.
You're handing that to her,
And I'm getting the next one
and
while
you're
she's
doing the
that.
next one, exactly. So you see, otherwise, we're going to pull it all, so you've got a friend, and you can really inject it, because it really isn't into it. It's actually coffee creamer is what it is, so you see what that does to it. All right, so we've got the monitors back on, assess the airway. Now, What's the other thing you do for neurologic symptoms from local anesthetic toxicity? Oxygen, I'll give you that. We've got oxygen on. Let's say it hasn't progressed quite this fast. What's the thing you do for the neurologic symptoms of toxicity? The answer is Versed. Benzodiazepine, yeah. Versed, yeah, exactly. So that will we be giving here too?
Yeah, I was like, because we don't have Ativan.
Right. So let's so it's going to be benzos, and what do we have immediately available? Versed, right? So we're not going to keep Versed in here, but we know that's something we're going to grab.
So
All right.
what is the dose for Versed for a seizure?
Is how much it takes.
Oh, fair enough.
I'd start
Right.
with 4.
And if there's not a doctor in here, by this time there's a doctor in here, right?
Right.
Now he's out there drinking coffee.
Yeah.
All right,
Yeah, he
so-
would be.
So we got the bolus started. We got the second one started. So someone else, as you know, you've drawn out the
Come on,
two
Misty.
50s.
Right in here.
Some more.
You are hooking up the tubing because we're going to be starting infusion, right?
So
You're
does that
open
have
to
to have special tubing?
No,
I never,
just
I didn't
regular,
think.
just regular tubing. Good question. We got this on. We checked the blood pressure. At the moment, it's okay. We're watching seizure activity. Has it changed? You know, has it stopped? If it hasn't, we're going to bolus again. We're watching because we know we're escalating towards cardiovascular symptoms, probably. All right, so we talked about the infusion, and okay, what's the infusion rate?
Infusion
fast
rate
as
of
you
the
can.
lipids? 100.
The answer is who cares? There is a real book number. The answer is 0.25 mLs per kilogram per minute by the book. But you know what the answer is?
Open it
Start
up.
it running. We'll figure out the numbers later, right? It's not going to be an exact amount. This is a make-do situation. We're going to make it happen, okay? And then, in fact, if that infusion rate's not enough, you know what we do? We double it. So we're just going to go. We're just going to get it started, and there we go, right?
Right.
Here's what happens next. Obviously, a little bit slow to get the intralipid going. Now, her blood pressure is 60/40. Heart rate has gone down to 30, multiple PVCs.
Give me some epi.
That's exactly where I was going. How much epi should we give?
One
What?
ml. One.
What else? 1 ml, one. All right, we have a vote for 1 milligram. Does that sound reasonable?
That's where I would start. I mean, that's.
You would start, so you would give one, see what happens, possibly give another one.
Right. So you start with one.
Do we start with ephedrine since he still has a blood pressure? No. Because you're expecting it to go
Well, it's already low,
What was the heart rate?
30, with multiple PVCs.
But we're still pulse.
Right.
And are they talking? They're not talking to us already because they were having
seizure activity.
Mm-hmm. So a milligram's a good place to
we-
start.
yeah.
We'll do a milligram, maybe another one after that.
milligrams and another milligram and 2 milligrams of epi.
I mean, I don't want to tell him
Instant
into
blow off.
It is.
hypertension crisis
Hey, you
here.
said do it.
Okay. Well, I didn't say do it. I said how much would you give?
Oh, well,
All
I
right.
said
So
what?
brilliant. I know everyone studied for ACLS. So you know the answer is. Here's what the dog studies show. They're going to do this for real people. They give an outrageous amount of local anesthetic IV to dogs, make them have neuro and cardiovascular symptoms or in asystole. They give intralipid and high dose epinephrine, or intralipid and small doses of epinephrine. The ones that get just intralipid do the best. The ones with high dose epinephrine do the worst, and here's why. His blood pressure is 60/40. Maybe it's getting worse. Maybe the other things are happening. But intralipid is so effective. Within 1, 2, 3 minutes, it's gone. His blood pressure is back to 129/71, plus 2 milligrams of epinephrine. I'm not. I want somebody to say that.
Yeah.
That's exactly why we do this. Why would you do it? That's exactly what you think. Now his blood pressure is 400, and he can't move the other side of his body. Right? Okay.
He's
Right. So the answer is so here's where we are. The general concept would be this. I see it happening. I know pressure's low. In general, it's better to just kind of let it ride out. Give this time to work. If you what? What was that? Okay. So the idea is either let it stay low, let it slowly come around. If you're getting worried it's getting lower, if you're getting into asystole, CPR, give epinephrine. But if you're giving epinephrine here, it's going to be less than 10 mics per kilo as you give a dose. The idea is you can give some epinephrine if you're concerned. It's not proven it's going to make a difference. You might give some, but you're going to give it cautiously because in a little bit of time, the blood pressure is going to be normal again, and we don't want them to go through the roof. Right?
Right.
Awesome. Awesome.
His
All right. Okay, so this patient also now, we found in this process difficult mask intubation, poor respiratory effort. Although our CRNA left, oxygen saturation had gone down to 82%, and they've been intubated. Okay, so pretend like you're intubated.
You're intubated. Am I bagging or?
That's what I was going to say. So yes, we are, because they're not breathing. Would it be better in this situation to just give some slow respirations, or would it be better to go fast and furious?
So what you're asking is, should we hyperventilate?
Slow or hyperventilate?
Yes.
I would hyperventilate because my doctor just told me.
What a wonderful answer. It's convenient that the person not having the seizure was also a trained anesthesiologist and a regional anesthesia specialist. That's awesome. So why do we do that? The reason is this. Hypoxia and hypercarbia lower the seizure threshold. So whatever else we know CO2's climbed because it's been 3 minutes since it's really been breathing. I know oxygen saturation's 80 or something like that. So we get it up fast, and if we have to hyperventilate to help, maybe that's going to help.
So when we intubated, we use one of our little CO2 things, right?
Mm-hmm.
We totally know what it is.
Okay, so here we are.
Goats, my goats.
We're in this crummy situation. Here we are. Seizures abate, blood pressure normalizes, PVCs are gone, returns to spontaneous ventilation. We're able to extubate them. Patient is beginning to communicate, looking pretty good. What do we do now?
We'll keep monitoring them,
Absolutely.
send them to the hospital.
Yeah, I like that.
Yep, there's going to be it. Yeah. How long do we keep this going?
Until my doctor tells me to stop.
That's a good answer. That's a fine answer. So, by the book is at least 10 minutes after the last cardiovascular symptoms. I'm going to say that's conservative. I think that means it goes longer. You also are going to take every case. You know, this is likely a rapid IV uptake because of macerated the tissue. So this, you know, so we could treat the seizures. They come back around, and then we don't have quite enough lipid in our body. We start going back the other direction. So at least 10 minutes. I would say probably longer. And then we can keep them on telemetry for at least 12 hours. And we're not staying overtime, right? So they're going to the hospital, right?
So how many bags of lipid do you think we would go through in an emergency situation like this?
We're never going to have this emergency situation happen. But
If
we
in
have
the world of
probably two, right?
sometimes
Because
happens.
these are actually 250 bags. So you gave 100 bolus. You may bolus again a little bit more out of that. 20 or, you know, so you're going to probably run through the
First bag, and then have
with
another
bolus
bag
and some more, and you got another
hanging
one ready.
while they
Right.
leave us.
And the fact is, you got 2 bags here, 2 bags there,
I just wanna
and
make
there's
sure
another
we
2
have
bags. You have more
enough
than a
bags.
reasonable amount. Okay, so all this stuff happened. What are the red flags? What, I mean, if I was going to say, yep, I told you that was going to happen, what's the stuff about this case that makes it seem like this might have been more likely to happen than just kind of your everyday average?
The
overweight.
BMI, because it's
Yep.
a harder.
Difficult anatomy.
Let's see. Patients
And
who was
how anxious she was.
the anxiety.
Very good. So what that means is all that anxiety means I ended up sort of over sedating her. She's already not that, you know, not the
Right.
sharpest pencil in the drawer anyway. Give her some Versed. I'm not really able to communicate. So as we're doing it, and we aspirate, we inject some, we say, now listen, while we're doing this, if you get, what are the
The
3 symptoms?
numbness and mouth down the hand.
Not hand.
Or the ringing in the ears.
Ringing in the ears,
Metal taste.
Yeah.
numbness and tingling,
Come on.
running lips,
I
metal
got it.
taste.
You did
Can't
good.
hear the peanut gallery back there.
And ringing in the ears. The 1, 2, 3. Okay, everybody knows that phrase. You can say it in your sleep. 1, 2, 3. 1, 2, 3. That's the bottom line. So as we're doing this, give me a little bit of time. Hey, while we're doing this, if you have a loud ringing in your ears, metal taste, numbness, tingling around your lips, you let me know, right? You have any of that? You have any of that? Okay, we're checking. We're gonna nip it in the bud whenever we can. So, but because you have that Versed, because they're so anxious, we're kind of like caught up. Now they're sedated, and I can't communicate with, and plus they're kind of a knucklehead anyway, hard to communicate with. So difficult anatomy, poor communication. We use the phrase meaningful contact when we do it. We have meaningful contact. We don't want to snow them. We want to know what's going on. They're the best monitor we have. Also, this is a procedure in the neck. So if I stick it accidentally in an artery here, sure, I give so much. It goes down to the foot, comes back down, It's going to take a lot of local anesthetic to make a difference. But if I put 3 cc's into the vertebral artery, seizure just like that, even with a small amount. The other is we macerated the tissue. That's really what happened. Tried and tried. So when you get this thing around the way, oh, that nerve block, God, it took them forever, man. I mean, they were in there going and going and going. That should already make you start thinking, this is somebody that may have a higher likelihood, and it's in their neck, right? We had, poor communication, and we had just given the bolus. Here's what I mean by that. As soon as we give a bolus, if we didn't do it exactly right, macerating tissue or in an artery, right now, within seconds to a minute, have a high, you have toxic plasma levels just like this, okay? If we've done a good job, in general, you still have plasma levels that start to develop, but it's going to be 30 minutes, an hour. We start building up over a period of time. This is going to help you for the next case study, by the way. So it's building up over a period of time. So this happened immediately. So we know they just gave a bolus. So when's the most important time to monitor them? Of course, it's always, but the answer is as soon as you've given this large dose. Right? You just give a big dose. We want to know in that short period of time if something went right or not. And again, I'm going to say the biggest is, in my opinion, is the biggest issue of all of this is we were in a rush. We were late. Yeah, they were difficult, but we were in a hurry. When we felt the pressure, the production pressure, and all this. That's when we'll make a mistake. And when hurry, oh, now I got distracted. I got to go over and do this, right?
Yeah.
Okay. So big picture. What happened to this person? Why'd it happen? So it was a high drug mass over a short period of time. That is intravascular uptake. So it comes from two choices: macerated tissue. So it's a high vascular uptake immediately, or a direct arterial puncture. What I'll tell you as a side, if this really was a direct arterial puncture, after a couple of cc's, they would have a seizure immediately. Would have been very unlikely to have the cardiovascular effects, right? It's just 3 cc's wouldn't happen. Who cares? We're just going to treat it and go fast. Okay. Teaching points here. Again, immediate and delayed increase in plasma levels. Intralipid is officially used for cardiovascular symptoms. This is not indicated for neurologic symptoms, but in this circumstance, perfectly reasonable because fast escalation of the symptoms, and we know cardiovascular symptoms are coming. Hypercarbia is bad, hypoxia is bad, right? Don't oversedate people. In general, we're using ropivacaine over bupivacaine because generally described to have a better safety profile. That is, when neurologic symptoms come on, they tend to max out, and then there's a little bit of time or a gap before the cardiovascular symptoms come on. That's not, and always, bupivacaine, the first thing that you see might be hypotension, arrhythmia, and they're having it present all at once. So ropivacaine has a little better safety profile. We'll save questions for end because I know you guys have other places to be in this. All right. Do you want to pretend like we're in the PACU, or you want to go to the PACU?
Let's just pretend.
Yeah.
Okay.